Well, everybody who made it, and we're grateful. To those who didn't, we'll have a recording, or maybe Dr. Epstein will agree to do it again. And I really appreciate everybody coming. Our speaker today is Dr. Jonathan Epstein, one of the top uropathologists in the world. He's speaking today about what patients need to know about their biopsies. He wrote me a letter recently saying he hadn't done a webinar like this in a while, and a lot had changed. So we're going to be getting an update on what's new. You should be entering questions into the chat box, and our lovely co-hosts, Jeff and David, who are wearing official Active Surveillor t-shirts. There you go. Not the walk and run, Bob, but Active Surveillor t-shirts. And they are available, but they're ridiculously expensive. At any rate, many of you have sent questions in advance, and we have those. I'm going to give you a little background on Dr. Epstein. For nearly 40 years, he was on the faculty at Johns Hopkins University School of Medicine. He built a huge second opinion practice there. Recently, he has launched on his own Advanced Uropathology of New York, Global Consultation Services. He has made significant contributions to the field with more than 1,000 publications in peer-reviewed journals, 73 book chapters, and 21 authored books. He's former president of the International Society of Urological Pathology and a founding member of Genitourinary Pathology Society. I'm going to put his contact information in the box. Oh, look, somebody else came in. So, and we're working. At any rate, let's see. Dr. Epstein, it's your turn.
Sure. So I'm going to be discussing, again, what you need to know about your prostate biopsy on needle biopsy. Well, I'll be covering mostly talking about cancer, grading. We'll talk about is Gleason score 6 cancer. Briefly talk about measuring cancer, perineural invasion, and then pathological aspects relating to active surveillance. Then I'll switch to talking about some precursor lesions, intraductal cancer, atypical intraductal proliferation, or AIP. What does it mean when you have an atypical finding suspicious for carcinoma? What does it mean when you have prostatic intraepithelial neoplasia? And I'll end with discussing some of the latest about artificial intelligence relating to prostate cancer grading and diagnosis. So in terms of cancer, one of the most important things with cancer is the grading of cancer. And the pioneers of the Gleason system were Donald Gleason, which the grading system is named after, who was a chief in the Department of Pathology at the VA hospital in Minnesota in the late 60s and 70s. Dr. Mellinger, who was the head of urology, and Dr. Baylor, who was a statistician. And that's Dr. Gleason on the far left. And this is the iconic Gleason schematic diagram from the late 60s and early 70s, where Gleason came up with patterns 1 through 5. 1 is very low grade, well differentiated, good prognosis. 5 is the most undifferentiated, worst prognosis. And the unique thing about the Gleason grading system versus any other grading system in the human body is what Gleason found out was that sometimes tumors had multiple patterns. So you might have a pattern 3 and a pattern 4. And what he found out was that the prognosis was somewhere in between a 3 and a 4. It wasn't based on the worst grade, which is what most grading systems use. So he devised the Gleason score system, where you take the most common grade pattern. For example, if 70% is pattern 3, you then say the 30% pattern 4, and you add 3 plus 4 equals to 7 to arrive at a Gleason score. The tumor is all one pattern, for example, all pattern 3, then in order to keep it in the scale, you just double it. So that's a 3 plus 3 equals 6. So theoretically, grades can range from a 1 plus 1 equal 2, which is a pure Gleason pattern 1, to a 5 plus 5 equal 10, which is a pure Gleason pattern 5. Now, what people don't recognize, even in the 1990s, so not tremendously long ago, about a fifth of prostate needle biopsies had as the highest grade a Gleason score of 2 through 4. And right now, that just doesn't exist. We never diagnose Gleason score 2 through 4, even though theoretically it's possible based on the Gleason diagram. So the reason why we don't diagnose Gleason scores 2 through 4 anymore, there were several international consensus conferences that I led. One was in 2005, and then one in 2014, where major changes was made. And one was that we stopped diagnosing Gleason score 2 through 4 and combined it all together. So on the right now is the more current schematic system. Now, in the more current schematic system, you still see that there's a patterns 1 and 2 above. Again, we just don't use that. We probably should just get rid of that. Instead, what we do is start at pattern 3. And Gleason's pattern 3, you can look on the left, and there were these structures that look like Swiss cheese, kind of punched out holes, which is Gleason, what we would now call Gleason pattern 4. In contrast, on the right, our current grading system, they look like a bunch of donuts, but it's all very uniform. All of them look like these single donuts. And those single donuts in Gleason pattern 3 are individual, well-formed discrete glands. So the big change now in grading is that Gleason 3 is a very homogeneous group that now has an excellent prognosis, where in the past, there was a more mixed prognosis. Gleason pattern 4 in the old system really only consisted of irregular cribriform, whereas now it's any cribriform glands, poorly formed glands, and fused glands. So this is now the different types of pattern 4, and we'll talk about especially cribriform glands a little later. And the word cribriform comes from the word sieve. And the way I think of it is literally Swiss cheese. Think of a slice of cheese, a flat piece of tissue that's solid, but somebody's punched out little holes in it. And that's what cribriform looks like. Pattern 5, the worst prognosis, is the one grade pattern that really hasn't changed from the late 60s to currently. The only thing I'll say about Gleason pattern 5, it's something that most pathologists in my experience have underdiagnosed. And I think that still exists today because pathologists are uncomfortable giving patients the worst possible diagnosis, even though it could be present, and that's important to recognize for both treatment and prognostic purposes. So some of the problems with prostate cancer grading. So I routinely review prostate cancer biopsies sent in by patients or clinicians, and either change it to a higher grade, 6 to 7 or even higher, or lower grade, downgrading from a 7 to a 6. Unrelated to active surveillance, I'll change other grades as well. So in about 20% of the time, I may be changing the grade of the cases that have been diagnosed by a pathologist in an outside institution. The correct grade is probably is critical, and it is the foundation for optimal treatment of prostate cancer. All treatments of prostate cancer, whether it's surgery, radiation, HIFU, cryo, etc., active surveillance, depends on the grade as the mainstay for what treatment's going to go on. Now, showing how this is still a problem currently, there was a recent study of 2 large patient cohorts over thousands of patients, where approximately 8% of biopsy grade group 2, that's 3 plus 4 equals 7, were downgraded to a grade group 1, 3 plus 3 equals 6, at the radical prostatectomy. Now, most likely, that's a result of that the biopsy was overgraded, and these biopsies that were called 3 plus 4 were probably 3 plus 3. And that led to these men to overtreatment, which emphasizes the importance of accurate biopsy grading. And you might think, oh, 10%, that's not too bad. But, that's 1 out of 10 men, and that could very likely be you or somebody else that's on this Zoom call. Now, why is there discrepant grading? So I would emphasize most pathologists are good diagnostically and grade accurately. They've been trained well. Some may grade inaccurately, either due to inexperience or lack of skill. And there are a few pathologists, I would say, who are just blatantly in error, but that's relatively few. However, what many patients may not recognize is that grading can be subjective. There are borderline cases, and those are the cases especially where you want to rely on pathologists with extensive experience. Now, let me turn to the whole issue, is Gleason score 6 cancer? And the reason why that's come about is because there's the concern that the fear of labeling it as cancer could cause problems, and that cancer could drive overtreatment. So the fear of death could play some role, and maybe if we remove that label of cancer, we could reduce unnecessary treatment of some of these low-grade cancers. This started out in 2013 with a publication in a high-profile journal where they maybe suggested another term like indolent lesion of epithelial origin, IDLE. There's been other names proposed. And this has been continued up until current times where there still is a kind of a controversial area. Just to show you how fear can play a role in men opting out of active surveillance. In the past, men followed in the Johns Hopkins active surveillance program opted out and underwent definitive therapy, even though they still qualified for active surveillance due to anxiety associated with living with cancer. So it's a real entity, this fear of cancer. And again, as I've mentioned, there's been these debates on and off, people who are pro keeping a cancer, arguing against with people who think we shouldn't use the term cancer for Gleason 6. So let me give you some of the evidence that I feel why Gleason score 6 is cancer. So first of all, under the microscope, it can look just like high-grade cancer, indistinguishable. Cancers lack basal cells, which are these cells around the glands. Only prostate cancer lacks basal cells, where benign, precancers, even intraductal cancer typically has a basal cell layer. Gleason 6 is locally invasive in the prostate like a cancer in contrast to benign glands. It can spread out of the prostate uncommonly and even rarely invade the seminal vesicle, which is even a worse prognostic feature. Probably the most important reason why I feel we should keep Gleason score 6 as cancer is the issue of upgrading Gleason score 6 on biopsy. So 20 to 30% of Gleason score 6 on biopsy will be eventually upgraded to a higher grade, either on subsequent biopsy or at radical prostatectomy. Now, even if you look at low-risk prostate cancer, the lowest risk, 1 to 2 cores with cancer, no core has over 50% cancer, the PSA is low with a PSA density of less than 0.15. Even then, there's a 15% upgrading of cancer from biopsy to what's going on in the entire prostate. Even if you say, okay, let's look at those cases with Gleason 6 and a PIRADS 1 and 2. So the PIRADS MRI looks favorable. There's still a 20% risk of upgrading within 6 years follow-up. So the problem with calling Gleason score 6 not cancer is that there's a significant risk of mislabeling a patient with unsampled significant cancer. In these patients, if you label 6 as not cancer, they'll be told you don't have cancer. They'll be called some other euphemism. And there's potentially a greater risk of them not being followed as closely with repeat biopsy, repeat imaging, and follow-up. I've never had a prostate biopsy, but I've been told by many patients it's obviously not a very comfortable procedure, and it's not something they want to have repeatedly. If all of a sudden you're told you don't have cancer, will certain patients say, why am I undergoing this miserable rebiopsying every 1 year, 2 year, 3 years, et cetera? Now, molecularly, Gleason score 6 is also cancer. It has this ERG rearrangement with the same frequency as higher grade cancers, and benign glands lack this ERG rearrangement. And also other molecular findings that we see in grade group 1 Gleason score 6 cancer, you don't see in benign prostate tissue, including point mutations, insertions, deletions, methylation of CpG islands within the GSTP1 gene. So molecularly, it is cancer as well. Now, I think this whole issue, is Gleason score 6 cancer, maybe had more relevance 10 years ago, 15 years ago, even 5 years ago than it does today. And why is that? Is Gleason score 6 cancer still as much of an issue? So in 2 recent studies of over 150,000 patients, the number of radical prostatectomies with grade group 1 or Gleason 6 decreased over the last 12 and 14 years from 47.5% to 14.1% in one cohort and 24.7 to 8.3 in the other cohort. So what that means is we're very uncommonly seeing Gleason score 6 being treated radically, anywhere from 8 to 14%. In that group of 8 to 14% that had a radical prostatectomy with Gleason score 6, some of them, because the biopsies were probably overcalled Gleason score 7, some of them had other worrisome features, worrisome imaging on MRI, very high PSA, or rapidly rising PSA, et cetera. So I think already active surveillance in the United States is becoming kind of standard of care for Gleason 6, where in the past, it wasn't that case. Now, the other issue to remember is grade's not the only thing that clinicians look at when they're trying to decide potentially, what's going on with the cancer. So you could have a Gleason score 6 with a PIRADS 5, which is a very worrisome lesion on MRI. You could have a Gleason score 6 with a high PSA or rapidly rising PSA. Or a patient may have a BRCA2 mutation, which is associated with aggressive cancers, and have a Gleason score 6. In all these situations, if you change Gleason score 6 to not cancer, would you not call the above entities cancers, even though they're all, most likely, there's much worse disease somewhere in that prostate? So for all those reasons, I think Gleason score 6 should still be called cancer. But I do agree it's important that patients change what they think they hear when they have Gleason score 6 cancer. A lot of that is up to the urologists. They're kind of the gatekeepers, the first people who are going to be telling the patients they have cancer. They have to reassure the patient, educate the patients, or encourage them to undergo active surveillance if that's what they would like to do. But also for the pathologist, it's important to report how we change the reporting of Gleason cancer grade so it more accurately reflects their behavior. So as I showed at the onset, the Gleason score system is kind of out of skewers. It goes from 2 to 10, but 6 is currently the lowest grade we report. So it's not like any other grading system we have in the body. Patients are told they have a 6 out of 10, and some patients may logically but incorrectly think they have a tumor in the middle grade of the spectrum, which still could contribute to their fear of cancer. Problem also, Gleason 7 is not homogeneous. 4+3 is a much worse prognosis than 3+4. And often 8 through 10 is kind of lumped together as one group when it's not homogeneous. 9 and 10 is much worse. So in 2013, I and my colleagues at Johns Hopkins came up with a grade group system, which is 1 through 5. 1 is less than or equal to 6. 2 is 3+4. 3 is 4+3. 4 is Gleason score 8, and grade group 5 is 9 and 10. And if you look at radical prostatectomy, so we don't have the issue of sampling. Grade group 1 or Gleason 6 has a 90% cure rate. 3+4 has an 88% cure rate, drops significantly to 63% with 4+3, 48% with the Gleason score of 8 or grade group 4, and then 26% with grade group 5. Now, you may wonder why it's not 100% with grade group 1, because we've shown if you have a pure grade group 1 or 3+3 equals 6 after radical prostatectomy, it's impossible to have metastatic disease. Now, the reason why that's 96% is some of these patients have local recurrence due to, for example, positive margins. The grade group system is correlated with multiple outcomes, biochemical recurrence, metastases, mortality following different types of therapy. And the whole thing is grade group 1 as opposed to a 6 out of 10. 1 sounds out of a 5. We know it's an excellent prognosis. As I said, you never have metastases with a grade group 1 if it's sampled well. It's avoid the issue of what's happened to grade groups 2, 3, and 4, and 5. Again, it's all lumped together as grade group 1. Grade group 2 is much better than 7 out of 10. It has an excellent prognosis with rare metastases. But now with grade group 3, we have a clear separation. It's not all Gleason score 7. It's 2 versus 3. It's clearly separated. And grade group 4 separates out versus 9 through 10. And grade group 5, we don't have to make the distinction of 9 through 10. It's all pretty much bad disease. Now, it's recommended still to keep using the Gleason system. At some point in time, we may drop the Gleason system and only use grade groups. But currently, the way we report it is we report that there's prostate cancer. We give the Gleason score, for example, 4+3 equals 7. In parentheses, we'll say what grade group it is, grade group 3. And then, as I'll talk about, we also mentioned percent pattern forward. So that's what should be recommended, plus the extent of cancer. And this has been accepted by all the major urology groups, the pathology groups, the cancer staging groups. So everybody should be using the grade group system. It's not everyone adopts the latest, but everyone should be. And on your pathology reports, you should have your grade group. But can we do better than just splitting Gleason score 7 into 3+4 and 4+3, meaning grade group 2 and grade group 3? So out of the most recent consensus conference in pathology for grading, it's been recommended to report the percent pattern 4 with Gleason score 7 on biopsy. So in the past, you might have gotten a report saying adenocarcinoma of the prostate, Gleason score 3+4 equals 7, involving 20% of one core. Currently, what should be happening, it doesn't, again, not all pathologists are doing it, but what should be saying is how much pattern 4 is there within that 3+4, because it can range anywhere from a little bit of 4. So you could have an adenocarcinoma of the prostate with less than 5% pattern 4, which is still pretty favorable. Or you could have an adenocarcinoma of the prostate, Gleason score 3+4 = 7, almost 50% pattern 4, meaning bordering on a 3+4 and a 4+3. That's more worrisome, involving 20% of a core. But if you get a pathology report that just says the top 3+4 = 7, you have no idea where you are in that spectrum. Now, the rationale for reporting percent pattern 4 for grade group 2, 3+4 = 7, is mainly with active surveillance. So with increased utilization of active surveillance for many patients with low risk and very low risk, which is Gleason score 6 prostate cancer, some urologists are also considering active surveillance for selective favorable intermediate risk, which is low volume grade group 2, 3+4 = 7. And we'll talk about that a little bit more, depending on life expectancy and other clinical and radiological factors. So reporting the percent Gleason pattern 4 in patients with grade group 2 may determine active surveillance eligibility. So pretend you have two different patients. This is a schematic needle biopsy. And so on the top, you have a case of a 3+4 = 7. 95% of it is pattern 3. 5% is pattern 4. That patient could be, a candidate for active surveillance still with just a little bit of pattern 4. On the other hand, if you had a separate patient with a 3+4, where it's close to 50% pattern 4, bordering on a 4+3, I would recommend that patient not going active surveillance. But again, if you just report 3+4 = 7 without percent pattern 4, there's no way to know what are these situations you're dealing with. Now, there's still a rationale for reporting percent pattern 4, even when you have a 4+3 needle biopsy. Not for active surveillance, but it could impact radiation therapy. So grade group 2, which is 3+4 = 7, is called favorable intermediate risk. And those patients typically do not get adjuvant or hormone therapy prior to radiation. But grade group 3, 4+3, which is unfavorable intermediate risk, often gets hormone therapy prior to the radiation. Again, pretend you have two different patients. One's a 4+3 with 90% pattern 4, 98% pattern 4 with just a little bit of 3. That's a 4+3 bordering on a 4+4. Typically, that patient would get hormone therapy prior to radiation. But if you had a 4+3 with just a 60% pattern 4, again, it's kind of bordering more on a 3+4 = 7. Most likely, that patient would not be getting hormone therapy prior to radiation. But if we just report 4+3 = 7 without percent pattern 4, no way to distinguish these two different groups. Now, in terms of measuring cancer, everyone will get how many cores are positive. That's standard. What you will notice is that it's variable in terms of the other measurements of cancer. Some pathology reports will report the millimeters of cancer. Some will report the percent of cancer per core, and some could report both. In terms of whether to report millimeters of cancer or percent of cancer per core, for the most part, they're equal. Studies haven't shown one way is better. So either way, I would say, is totally satisfactory. Another area that often causes confusion is when cancer is discontinuous. And by discontinuous, I mean, pretend the red is a core of a needle biopsy, and all the red tissue is benign. And the only cancer are those two little blue spots of cancer separated by a lot of benign tissue. There's potentially two different ways the pathologist could report the extent of cancer on this biopsy. One is they could say the cancer involves only 5% of the whole area of the core, or they could say that there's small foci of cancer discontinuously involving 80% of the length of the core, which is what I do. And the reason why I report it as 80% is studies have shown that in the vast majority of cases, when you get a needle that has discontinuous cancer, it's one big tumor where the needle just goes in and out of the plane of the section of the tumor, as opposed to representing two separate small tumors. So in general, you should consider this 80% involvement. Now, where this is confusing for patients is you may get two pathology reports from two different pathologists if you get, for example, a consult from another pathologist. One might report a case like this as 5% of the needle with cancer, and the other pathologist could say 80%. And when that happens, it's usually because of these discontinuous foci. Perineural invasion is another finding on needle biopsy. It's an important finding that pathologists should note. It's an independent predictor of extraprostatic extension at radical prostatectomy, and it's a predictor of progression following external beam radiotherapy. Even more than grade, it's easy to assess, it's reproducible, and again, it should be on the pathology reports. Now, what are the pathological aspects relating to active surveillance? So in addition to pathology, there are other factors. One is life expectancy. A man who has a shorter life expectancy would more likely potentially go on active surveillance than a man who has 30 or so years of life. Again, this is not a yes or no or given, but it's something that gets factored in. Patient preference is critical. I've talked to patients where they just say, I want it out. I don't care if I'm told this is an indolent cancer. I don't want to wake up every day with the thought I have cancer in me. I just can't live like that. And other patients are very, comfortable with it and say, that's fine. I'll wait for my next year, my biopsy. And, in between that, I can live with it and not let it, affect my life. Cancer extent, whether on staging and imaging, is important. Needle biopsies that I've talked about, and I'll discuss that relative specifically to active surveillance, grade, extent, and some other findings. And then PSA is very important. And the reason why PSA is so important is PSA is kind of a global measurement of what's going on in the prostate. Not perfect, but it still gives an overall indication of how aggressive and how much cancer there's there. So sometimes you may have a biopsy missing the worst cancer, but if the PSA is very high, that's a clue that something else bad is going on. And the two PSA measurements that's often done, there's a lot of them, but the most common one is PSA and PSA density. So back in 1991, we were the first ones, 1994, sorry, we were the first ones to come up with criteria, both pathological and clinical, for active surveillance. So right now, active surveillance is very commonplace. Everyone thinks it's standard. But back in 1994, this was a radical concept. It was radical to say, we're not going to treat cancer. Back then, all cancers were treated. So we came up with a preoperative model. Again, this was the first model to predict insignificant cancer. And we call this very low risk cancer. So stage T1C was non-palpable on digital rectal exam, Gleason score 6. But in addition, we looked at volume of cancer, meaning less than 3 cores involved by cancer. No core had over 50%. And the PSA density, which is where you take the PSA divided by the volume of the prostate on the imaging, was less than 0.15. Now, there are variable inclusion for active surveillance. Those are the criteria we came up with. But again, what you have to recognize is we came up with very stringent criteria because back then, people were saying active surveillance is dangerous. This is blasphemy. You shouldn't do it. Patients are going to die. So we had to come up with criteria that labeled the best of the best criteria that these patients would do well so that active surveillance would be adopted. If we expanded the criteria for active surveillance initially and certain patients didn't do well, potentially that would have been the death of active surveillance. But now we've expanded it. So most people allow a small palpable nodule on rectal exam, although most patients still are non-palpable. Most urologists and clinicians still require a PSA of less than or equal to 10, but some allow a little higher. But most people do not use PSA density, even though numerous, I think almost all studies have shown PSA density is better than PSA. And the reason why PSA density is better, you could have a high PSA with a huge BPH prostate, and that PSA is being driven by the benign prostate, not the cancer. So it could be misleading that you have a bad tumor, but PSA density factors out all the size of that prostate due to BPH and more accurately gives the PSA being contributed due to cancer. Almost all people, your clinicians still use Gleason score less than or equal to 6 as the best criteria for active surveillance. But as I mentioned, more and more selected men with 3 + 4 = 7 are being considered for active surveillance. as I mentioned early on, the most stringent criteria, there's some limit as to how many cores have cancer or percentage of cores with cancer, but some clinicians are not using any volume of cancer as a criteria. Same thing with how much of the core is involved. Again, it's variably being used as criteria. And same thing whether it's unilateral or bilateral. Also, some people are using it as criteria, some are not. Now, when we talk about predicting biopsy reclassification, meaning somebody's on active surveillance, they're doing well on active surveillance, and then they go on for a biopsy down the road. We use the term biopsy reclassification. We do not use the term biopsy progression. And that's because your cancer is not, if you start out with a Gleason 6 and you have a Gleason 7 on your next biopsy, it's not that that Gleason 6 became a Gleason 7 and this tumor became more aggressive. It's only that there was Gleason 7 there earlier on. It was just missed on that first biopsy. So when we talk about biopsy reclassification, we're talking about favorable pathology on the initial biopsy, followed by more adverse pathology on the subsequent biopsy, usually grade. Okay, most of the time it's going to be grade, but it could be more cores involved, or it could be more percent cancer core than the original as well. Now, there's been a lot of studies to look, can we predict which men on active surveillance are more likely to have reclassification? Who is more likely to end up having worse disease on follow-up, maybe needs closer follow-up, maybe should be counseled, it's more risky to be on active surveillance. So one thing is looking at PSA. And if you look at PSA and then looking at patients who have disease reclassification later on, it's all over the map. Sometimes the PSA goes up, but sometimes the PSA goes down, sometimes it's pretty stable. So PSA is important to diagnose prostate cancer and say who's potentially a good candidate for active surveillance. But once you are diagnosed with prostate cancer and you're on active surveillance, pretty much the PSA is not that helpful. You still get it measured, and the one situation where it could be helpful is if all of a sudden it rapidly increases. But we're talking about, a significant, huge jump. That could mean something. But slight fluctuations in PSA going up and then potentially going down again isn't so useful. So we came up with a reclassification tool when I was at Hopkins to try to help predict which men are more likely to have reclassification when they're on active surveillance. And these are the important features that are predicting who's more likely to have worse disease on subsequent biopsy. One is if you've been diagnosed before 2005, and that's because back before 2005, the Gleason system was very different. And we called Gleason score 6 back then. Today, we would call it Gleason score 7. And so that's why that was an issue. If you were diagnosed before 2005, your grade might not be accurate. Age, the higher the age you are, the more likely you are to undergo disease reclassification with higher grade later on. And that's been shown in general that there's a correlation in higher age with more aggressive disease. Unclear why, it's just a fact that we've seen. PSA density at the time of your last biopsy is the higher the PSA density, the more likely you are to undergo grade reclassification. If you have bilateral cancer, that's also an increased risk that you're going to have Gleason 7 if you started out with a 6. And if you had low risk versus very low risk, also that's a parameter where if you have low risk, you're more likely to have a Gleason 7 than if you had very low risk. And very low risk is Gleason score 6, but with very little cancer on biopsy, whereas low risk is pretty much just Gleason 6 without factoring in how much cancer is on the biopsy. And then the longer you've been on active surveillance without a biopsy showing a Gleason 7 or more, the more likely you're going to stay without grade reclassification. And that makes sense. If you've had 5 biopsies or 4 biopsies, all Gleason 6, that probably means you truly have a Gleason 6. It's not like there's any Gleason 7 hiding there in your prostate. And the way you use those basically that data is you factor in your age. Let's say you're 70 years old. You look up here and you say 70-year-old is about 32 points. You look at your PSA density, it's 0.3. You might get 10 points, et cetera. You keep on factoring all these things. You add up your total points. And then based on your total points, you say, what's your chance of having a grade reclassification? And what we found is that if you use this tool, 60% would have a chance of grade reclassification going from a 6 to a 7 with less than 20% chance. So at least with this tool, 60% of the men on active surveillance, you could help reassure them that they have a high probability of staying on active surveillance, maybe space out some of these repeat biopsies, and keep people on active surveillance. What other things can you do other than just the biopsy, morphology, or pathology that might help you, reassure you, or potentially say that maybe what you have is more aggressive? And there are various molecular tests out there that are commercial tests, and you can have your biopsy sent off for those tests if you ask your clinician. The one that's probably one of the most frequently used, and the one that we use at our institution, is the Decipher test. We use it basically on all men with a Gleason score of 3 + 4 = 7, or even 4 + 3 = 7, and all men with Gleason score 6 that have a lot of Gleason score 6, where they're higher risk of potentially having Gleason score 7. And what's been shown is that the increasing of the Decipher score is associated with an increased odds of upgrading. Even if you stratify by grade group, it can also, within grade group 1, Gleason 6, help to say who's going to have a Gleason score 7. Not as helpful within the 3 + 4 = 7 group in terms of predicting what's going to happen. The way I look at the Decipher test, it's not something that I would base all my decisions on. It's just one more factor. If you're on active surveillance, you're a little nervous about it, you get the Decipher test back, it has a very low score, that's reassuring. You know, if some of your findings on pathology are not that favorable and you get a Decipher test and it's more worrisome, you know, that may push you to active surveillance, to active treatment. So, big question for active surveillance currently is men with Gleason score 3 + 4 = 7, grade group 2, is it safe? And with that, the question is, are there subgroups of favorable Gleason score 7, 3 + 4 = 7, who would be candidates for active surveillance? Based on looking at the extent of the cancer, maybe, the percent pattern 4, and whether it's Cribriform or not Cribriform. So hence the National Comprehensive Cancer Network, which helps give guidelines, and probably the most widely used guidelines used for treatment for men in the United States, or all patients with cancer in the United States, has a favorable intermediate risk. So favorable intermediate risk means it's a 3 + 4, grade group 2, not 4 + 3. Less than 50% of the cohorts are positive with cancer. Less than a half of your cohorts have cancer. And at most, it's either a clinical, pretty big tumor nodule on rectal exam, or you have a PSA at most 10 to 20s. So what's the outcome for this favorable intermediate risk? So if you look at the top curve, which is low risk, so that's Gleason score 6, basically. If you look at the two top curves, one's in green and one's in red, you can see they overlap. So that one curve is low risk with active treatment, meaning radical prostatectomy or radiation. One is low risk cancer, Gleason score 6 with active surveillance. So what that shows is, active surveillance patients do just as well on active surveillance as if they had active treatment, whether it's surgery, radiation, cryo, HIFU, et cetera. And that's, the argument to keep Gleason score 6 on active surveillance. But now if we look at the bottom curve, that's favorable intermediate risk, 3 + 4, again, with favorable features. The green is favorable intermediate risk with active treatment. The red is favorable intermediate risk with active surveillance. And you can see that those patients with favorable intermediate risk with active surveillance have a worse overall survival than patients with active surveillance. So not all men with favorable intermediate risk are doing well on active surveillance. And the question is, can we find a better favorable intermediate risk group? So we did this study, and when we looked at it, if you look at very low risk prostate cancers, again, that's Gleason score 6 on biopsy with very little bit of cancer on the biopsy, there's about a 5% chance of having bad pathology at your radical prostatectomy. Findings in your radical prostatectomy that, if you knew that what was going on in your prostate, you wouldn't have wanted to go on active surveillance. That's not favorable. Low risk still does pretty well. If you have only a Gleason 6, and those patients underwent radicals, only 6% had bad disease in their radical. So again, working backwards, if you have very low risk or low risk and you don't have a radical prostatectomy, the chance of you having something unfavorable in your prostate is, 5%, not too bad. Again, considering you're going to get repeat biopsies over time to try to identify when you have those worst findings. However, if you look at somebody who has favorable intermediate risk on the biopsy, 25% of them have adverse findings in their radical prostatectomy, which is obviously significant. It's a minority, but it's a significant minority. Even if you look at favorable intermediate risk and try to even say, let's have a little bit of cancer with favorable intermediate risk. Less than 50% cores are positive, only 1 to 2 positive cores, no core over 50%, you still have about 19% with adverse pathology at the radical. So what this means is that favorable intermediate risk, even with relatively limited amount of cancer, are potentially not ideal candidates for active surveillance, just with that factor alone. Now, you could look at MRI. Some of those studies were done not using multiparametric MRI. And this was a study that looked at multiparametric MRI, systematic and targeted biopsy. And those patients that had on biopsy a favorable intermediate risk, even who had a multiparametric MRI, still had a 12% risk of adverse pathology, meaning the tumor was out of the prostate. So one of the things is there a cutoff for percent pattern 4 that would be helpful to identify which men with a 3 + 4 = 7 can undergo active surveillance? And there's also problems of how to measure that percent pattern 4, whether you do it the maximum percent pattern 4 per core, or you average it of all the positive cores. But what I would say is we really don't have long-term follow-up of men on active surveillance with 3 + 4 = 7, with low percent pattern 4 or different percent pattern 4s to see how they're going to do. That's ultimately what we need to make this decision. Now, what about cribriform glands in active surveillance? So cribriform glands in active surveillance, when you look at that, the vast majority of studies on prostate cancer with cribriform architecture just demonstrate an association between adverse clinical outcomes and molecular features that typically see with more advanced disease. So cribriform cancer typically is a bad actor amongst pattern 4s. So the question is, if you have cribriform glands with a 3 + 4, should it rule out active surveillance? The problem is these cribriform glands, which look like little Swiss cheese, are variable. They could be small cribriform glands and big, and it turns out that studies have shown that most of the time it's the large cribriform glands that have the worst prognosis. So when I give a report, I always say whether the large cribriform glands are present or absent. I don't comment on small cribriform glands because I don't think those are the ones that are necessarily associated with the bad prognosis. And I do that for both grade groups 2 and grade group 3. I would say that's a minority of pathologists are reporting cribriform glands being present and whether they're large or not. I think that is something that the societies have recommended, but again, at this point, it's not become a majority practice. But we still need long-term follow-up studies on men with, for example, non-large cribriform glands and see how they do. Now, another is, let's say you have a Gleason score 6, you're on active surveillance, you get a biopsy that's 3 + 4 = 7. So we've reclassified you to a grade group 2. Can you potentially still stay on active surveillance? In the past, that would have been the trigger for treatment, like radical prostatectomy or radiation. So we did a study and found out that the majority of men who are on active surveillance, they have grade group 1 disease, they get reclassified on rebiopsy to a 3 + 4. When you look at those men that have undergone radical prostatectomy and you look at their prostate, most of them still have favorable findings in their prostate. And in retrospect, those men could have stayed on active surveillance. They didn't need radical prostatectomy. And what we did is we try to say, could we have predicted on the biopsy and clinical factors before they had the radical prostatectomy, which men with a Gleason score 6 on active surveillance that eventually has a 7, which of these men potentially could stay on active surveillance? And what we found is one of the most important criteria was a low PSA density of less than 0.2 and having no perineural invasion on the biopsy. So potentially what our study showed is we can increase the number of men who stay on active surveillance, even if they have a 7 on their subsequent biopsies. Now, what about other findings on biopsy related to active surveillance? So some of the findings that do not affect active surveillance are atypical foci. So if you have cancer, let's say Gleason score 6, and multiple other cores show atypical foci, you can just ignore those. Same thing with high-grade prostatic intraepithelial neoplasia. Even though the word says high-grade, it's not cancer. It's actually very indolent. Cancer is the important thing, not high-grade PIN. So you can pretty much just ignore high-grade PIN if you have cancer somewhere else on your biopsy. Now, what are the factors that do affect active surveillance? And probably the most important one is intraductal carcinoma. So intraductal carcinoma is typically associated with high-grade invasive cancer, not always, but typically. So if you have intraductal cancer associated anywhere in your biopsy, in addition to your Gleason 6, for example, or 3+4, and otherwise you might be considered for active surveillance, I would recommend, and all the pathology societies recommend, not undergoing active surveillance if you have intraductal cancer. Now, intraductal cancer can be difficult to diagnose, so if that's the case, you might consider a second opinion to confirm it. Now, there's also another entity that may affect active surveillance, and that's called atypical intraductal proliferation, or AIP. And that's glands that have some but not all the features of intraductal. The key thing is there's a spectrum of AIP. There's AIP that's not really suspicious for intraductal cancer, and there's AIPs that are really borderline and suspicious for intraductal cancer. Maybe on repeat biopsy, there would be definitive intraductal cancer. So if you're diagnosed with AIP, for example, and you have Gleason score 6, or maybe you just have AIP by itself on your biopsy, I think it's important to discuss with a pathologist or get a second opinion to find out what type of AIP is it. If it is AIP suspicious for intraductal cancer on biopsy, and otherwise you might be a good candidate for active surveillance, in my opinion, I would recommend a repeat biopsy before undergoing active surveillance to make sure you do not have intraductal cancer. What about atypical needle biopsies? How often should you see that on biopsy? It's only about 5%. And the risk of cancer following a diagnosis of atypical, if that's all you have in your biopsy is atypical, no cancer, the risk of subsequent cancer on biopsy is about 40%. That's pretty high. It's higher than if you have a benign biopsy. Even some men with benign biopsy will have a risk of cancer just because the cancer was missed. But it's definitely an increased risk for cancer if you have something atypical, suspicious for cancer on your needle biopsy. So what I recommend is follow-up as warranted. Some urologists might do serum or urine tests to see, how likely there's cancer. Reasonable to do imaging, MRI, to see if there's a lesion to target. In some cases, urologists may do a repeat biopsy, biopsying the entire prostate, biopsying any lesion seen on MRI, but also doing more cores in the atypical side, but that's where more likely the cancer is going to be. Now, there are some urologists who will not do a repeat biopsy after an atypical initial biopsy. And their argument is that most of the time, the cancers we're going to find after a repeat biopsy for an atypical initial diagnosis are going to be grade group 1, 3, 3, 6, and likely I wouldn't even treat those. So why do a repeat biopsy after something that's atypical? However, there's about 20% of the time, if you have an atypical on biopsy and you eventually are found to have cancer, that cancer is higher grade, and you would want to diagnose it. So it's a judgment call if you have atypical on your biopsy, something to discuss with urologists, and about what you want to do in terms of follow-up. What are atypical biopsies? What does it mean when you have something atypical suspicious for cancer? Some of these are cancers. They're just minimal and very difficult to diagnose on these thin core needle biopsies. But some are also benign mimickers. There's a lot of benign, non-cancerous mimickers of cancer that a pathologist who's not that comfortable might call atypical. And what we've shown is that the majority of biopsies that are called atypical by non-expert pathologists can be diagnosed more definitively, either totally benign or as cancer, by an expert prostate pathologist when they review it. So if you had something called atypical, that's definitely something, if it were me, it would be reasonable to get a second opinion on. What about prostatic intraepithelial neoplasia, or PIN? Hopefully, you do not have a report calling low-grade PIN. It's recommended not to comment on it in the diagnosis. It has no prognostic significance. It's not reproducible. And if it's commented on, patients may undergo unnecessary procedures and concern. High-grade PIN happens about 5%, so it's about the same as an atypical biopsy. If you have a single core with high-grade PIN, which is the most common scenario, you do not need a routine repeat needle biopsy, in contrast to what used to be recommended. If you have high-grade PIN on multiple cores, it's unclear. There is an increased risk of cancer approaching about the same as an atypical needle biopsy. So it's basically the same recommendation goes for an atypical needle biopsy. May get a repeat biopsy, may not. Probably should be followed though. Finally, I'll talk about AI, or active artificial intelligence, in prostate biopsies. So what happens is the slides have to be scanned in order to basically be analyzed by the computer. These scanning equipments cost hundreds of thousands of dollars. They're very expensive. Most labs do not have it. Nonetheless, even if your biopsy is done in a lab without one of these scanners, your biopsy slides can be sent to a lab with scanners, so AI can be done on it. And there are some commercial programs out there that are doing AI on biopsies to look for and give you the your risk for being on active surveillance. So anybody can get these tests done, even though your labs might not have some of these scanning equipment. Again, the slides can be sent out to be scanned. And then what happened, how AI came about for prostate, is these scanned slides were then analyzed by computer programs. And so the computer programs for diagnosing and grading prostate cancer analyzed many, many biopsies that were called benign or called cancer and graded as various cancers. And then basically said, okay, this is what the grade is and what's benign, what's cancer, based on what all these biopsies looked at by these pathologists. However, these computer programs, AI, are only as good as who's diagnosed and graded the cancer that was sent off to be analyzed by the computer. Also, the nature of the cases can vary. So some AIs may be trained on bigger cancers and not as good as picking up small cancers, which could determine the accuracy of the program as well. Now, the whole purpose of AI is predominantly so that pathologists would avoid underdiagnosing small cancers, not miss cancers. And so because of that, what happens with AI, it is set for the maximum sensitivity to identify anything abnormal. Because what AI wants to say is find anything abnormal, we don't want to miss cancer. Now, if an AI machine says, or the program says, this is a benign biopsy, pathologist still has to look at the slide. It's not foolproof, but there's a very high likelihood that biopsy is benign and can reassure pathologists. So many pathologists, not me, because I'm comfortable when I look at the slide, but many pathologists, when they look at a case and they don't find any cancer, they're nervous that they've missed a cancer, and they'll look at the whole case all over again. And so having AI saying there's no cancer, in a sense, is like a second pathologist saying there's no cancer. So it avoids having to look at a case twice. In terms of grading, AI can potentially show greater standardization. It's more uniform, meaning, if a computer grades your case as 3+4 on a Monday, it's going to grade it as a 3+4 or the same on a Tuesday, where there may be some variability by a pathologist. And AI has shown that it's equivalent to pathologists with greater reproducibility. But what's not been shown is that AI is more accurate grading than an expert. Now, a potential problem with AI in prostate pathology is that there are a lot of benign mimickers of prostate cancer, and some of these mimickers are uncommon, such that the AI has not been trained to identify these mimickers and potentially will call them cancer. There's also variants, a lot of different variants or on subtypes of prostate cancer that are too rare to allow sufficient training of AI, that the AI is not going to recognize, and it's hard to what they're going to deal with when they get these unusual variants of prostate cancer, or even cancers from other organs or that come into the prostate, which can happen. The other problem with AI is the AI, for example, might be trained on all the material from one institution. But what happens is everybody's institution, the slides look different, they're processed a little differently, the routine stain looks different, they're cut at different levels. So even though the AI could do very well and be very well trained on one group of material from that hospital, once you start generalizing that AI program throughout all different institutions, may not perform as well. The other potential problem that I alluded to is that AI is trained to have maximum sensitivity. Again, it wants to find anything abnormal. And so studies have shown that AI will overcall some cancers. because it doesn't want to miss something. It has less specificity, meaning it's going to overcall some cancers. That's just the way it's set up. Now, you can't sue AI. They will say on all AI programs that are out there commercially for purchase, this is a test to be used with the pathologist, but we're not liable for anything. It's meant to be an aid, not a substitute for the pathologist. Ultimately, the reporting pathologist has to be responsible to either accept or reject the diagnosis proposed by AI. The potential pitfall is that pathologists, who are not the experts, but the routine pathologists, are going to place too much weight on the AI and say, well, the computer said, it's a 3 + 4, even though when I look at it, I don't really see the 4. Or the computer may say there's cancer there, and I think this is a mimicker. But the pathologist may say, well, this is a computer, and it's AI, I have to trust it, and basically go with the AI and potentially lead to diagnostic errors. And so this is something that I think we all pathologists, everybody in general has what we call as kind of a tunnel vision, that if you think something is something, even though you might be seeing something differently under your own eyes, you tend to go down that tunnel based on what you think it is. And here, what you think it is could be what the AI says it is. So in summary, there's a wealth of information that you can get from your pathology report. It does depend on the accuracy of the pathology. Critical, even though you don't know your pathologist, they're kind of behind the scenes. It's critical to have high quality pathologists to get the best diagnostic and prognostic information for your patients. Thank you.
Thank you, Dr. Epstein, and thank everybody for all the questions they put into the chat box. You can still put questions in. David Keller, Jeff McLennan, and I will be alternating on the questions. I'm going to start off with 2 or 3 questions, but before we launch in, Dr. Epstein, are you willing to stick around beyond 1:30 Eastern to handle some questions?
Sure, I'd be glad to.
Okay, I'm going to start off here. Some of these sound like personal health issues, but we're trying to look at this more generically. And I think, I know, Dr. Epstein, you know how to handle these questions, but I'm going to start out with one. Well, let me just ask you this. It seems that a lot of guys go shopping for pathology reports. They don't like that they got a Gleason 7, 3 + 4, so they're hoping to get a Gleason 6. And I know people who've gone out like 4 different pathology reports. What do you think about that? And also, if somebody gets a Gleason 6, do they stand pat, or do they double check on the Gleason 6?
Yeah, so I would say in general that you're better off getting a second opinion. So even, for example, I'll take the second question first. Even if you have a Gleason 6, you might feel, oh, that's reassuring, that's great, you feel in a good mood. Ultimately, you still want it to make sure what is your true grade, is it accurate? But you don't want to potentially go down a path treatment for a Gleason 6 when it's potentially more aggressive tumor. So I would recommend a second opinion, regardless whether it's a 6 or a 7, for example. 7 but could get downgraded, 7 could get upgraded to something even worse that you need different treatment. A 6 could get upgraded or could stay the same. Anything is possible. In terms of shopping around, typically what I would recommend is you choose one expert that you're comfortable with and stick with that expert. Because if you start going to 3 or 4 people and get 3 or 4 diagnoses, what are you going to do? It's going to be total confusion. Now, what you potentially could do, I mean, if you get a diagnosis from your main hospital and there's a difference of opinion by an expert, if you feel uncomfortable with that, you potentially get a third, and if the third expert agrees with the other expert, 2 experts agree, then you're all set. That's about the maximum I would do in terms of, quote, shopping around. But in general, I would recommend finding somebody that you can rely on and you can trust, has a quick turnaround time, so you're not waiting weeks for the pathology report, and go with that.
Okay. Now, Jonathan P., who's one of your graduates, asks, when you have a second read of the biopsy, what is the protocol to talk to the pathologist?
Right. So for my case, we give all the information possible that you can talk to me. At the onset, I put my email out there that people have access to it. Our website has my phone number. You can call me and talk to me. We make it as easy as possible to contact me. Initially, when I moved to this new institution, there were some hiccups trying to get everything set up, and we found, patients who were having trouble reaching me. So I just made it simpler, gave my personal phone number, email, so it's easy to talk to me. Not all pathologists like to talk to patients. I mean, it's kind of some people might think people went into pathology because they didn't want to talk to patients and be a clinician dealing with patients. That's not why I went into pathology, but there are some pathologists who feel, hey, that's not my role to talk to patients. But in general, if you have a question, a pathologist should be able to answer it, and you should reach out to them. If you can't get answers or reach out to them, again, potentially send it off for a second opinion to a pathologist who will talk to you.
I gotcha. David, why don't you field a couple of questions and then turn it over to Jeff?
Okay, Dr. Epstein, fantastic presentation. Rarely do I want to see a presentation again, but I want to see yours again, maybe a third time. Question.
So is that like a third opinion then, David?
Do Gleason cells, when they're first born in your body, if we're only looking at them from the 1 to 5 category, before they're combined to get a full Gleason score, do they start off as a 1 and then sometimes they get unhappy and they start to unform and malform and move to a 2 and a 3? How does that progression work? Because my follow-up question is going to be, how can people say that a Gleason 6 isn't going to metastasize if Gleason cells started off as a 1, but eventually they migrated up to higher grades? So I'm trying to understand the life of a Gleason cell.
Yeah, that's a good question. And we use the term dedifferentiation. When a tumor starts off good and in a sense becomes bad. That's the term we use, dedifferentiate. So the question is, does a Gleason pattern 1 or Gleason 6, let's just say Gleason grade group 1, we'll call grade group 1. Grade group 1 dedifferentiate to grade group 2, 3, 4, and 5 when it starts out. The answer is we don't really know 100% because at the earliest onset when these cancers begin, they're so tiny and microscopic we can never detect them and follow them. By the time they detect them, there are hundreds of millions of cells, basically. We think that in general, they do not dedifferentiate, get worse over time with any great frequency. And that's based on active surveillance. So that when you follow men with Gleason 6, the majority of these men will stay Gleason 6s. And the majority of the men where they go from a 6 to a 7, that 7 is found usually on the first or the second rebiopsy, so it's early on, where we think it's not that the 6 or the grade group 1 went to a grade group 2, it was just missed basically on that first biopsy. But it's very uncommon to have grade group 1, grade group 1, grade group 1, grade group 1, 10 years, and then grade group 5, or something bad. So now it does happen occasionally like that. And again, we still don't know if the grade group 1 dedifferentiated to a higher grade or there's a new cancer that developed that was a new high grade cancer 5 years, 10 years later. So it's kind of a hard question that we don't know. But what I think we can say that's reassuring for patients, the majority of time, the cancers we think do not get worse over time, and they don't get worse over time quickly, such that we can follow you carefully. And if they do get worse, or if it's a new cancer that's worse, we can detect it at a stage that's usually still curable.
Thank you. I really appreciate that. I'll ask one more question and turn it over to Jeff, and you can pass it back to me or Howard. In no particular order, what's the life of a prostate cell? I mean, do these, once it hits a slide level, do they have a long-term life so they can pass around from lab to lab?
Yep, a good question.
Are they fragile?
Yep. So what happens is I'll explain the whole process. So you get a needle biopsy, which is a hollow tubed core, very tiny core that gets jabbed into the prostate, either transrectally or through the skin transperineally. You get a core of tissue from your prostate. It's very floppy, just like your skin is floppy. And then what we first do is we fix it in formalin, and that basically kind of stops it from dying. it freezes it so it's going to be preserved. It's preserving. It's like pickling a tissue in a sense, like you
Okay.
pickle, pickles or whatever, so they can stay preserved.
Okay.
Once it's in that form, then we let it sit for a while and it's preserved. We then have to get all the water out, because what we eventually want to do is put that tissue in wax. And that wax is just like candle wax, no difference, paraffin wax. But wax and water are like oil and water. They don't mix. We get all the water out of that fixed tissue. We put it in wax. Once it's in wax, it's very firm. Now that it's firm, we can cut it super thin on these what's called microtome, which is basically a knife. So we cut it super thin, so thin that light can go through the tissue. Put that very thin slice of tissue that light can go through it on a glass slide. We then stain it so that we can look at it under the microscope. These stains have been around since the 1800s. They really haven't changed. And we put a piece of glass on top of it. Once that slide is made, that slide can last for hundreds of years and still look good.
Okay.
We also have a wax block that still has the tissue that hasn't been cut. We don't cut through all the tissue. There's still residual tissue in these wax paraffin blocks that if we have to do molecular tests or any other tests, we can still do that. And those wax blocks can again last decades and years, as long as they're preserved, don't get high heat, et cetera. So even if there's new tests that come out 5 years from now or 2 years from now, hopefully we still should be able to do it on that old material.
Thank you very much. Okay, over to you, Jeffrey.
Thank you, David. Hello, doctor. Going again back to the process of the biopsy, and I'm really driving towards getting the best quality tissue for you, the pathologist, to use. Would it be best to do like an in-bore biopsy and an MRI or a micro ultrasound, and then maybe apply AI to that? What's the best thing for the customer?
Yeah, so there are a lot of different newer kind of radiology techniques that are out there. I would probably defer more to the radiologists on this. Some of these are still, I would say, not standard of care. I would say standard of care is not the micro ultrasound. The standard of care is still multiparametric MRI, but even multiparametric MRI is not being done routinely for all men, probably still a minority of men, for their initial biopsy. What I would say is, for me, if I were having a prostate biopsy because of something worrisome clinically, typically an elevated PSA, I would have a multiparametric MRI right at the onset, because it's been shown that multiparametric MRI has a higher likelihood of detecting the worst cancers. It's not foolproof. What I see every day in my practice is most of the time, the multiparametric MRI, the targeted area, the lesion area that was abnormal in the prostate that was noted on MRI, that was then sampled on biopsy, most of the time, those targeted areas is the worst cancer. But occasionally the worst cancer is in the random biopsies, and MRI either misses the cancer altogether or misses the worst cancer. So it's not foolproof, but overall it is still better that it was done, because most of the time it's going to identify the higher grade cancer. So I think if you have a biopsy with multiparametric MRI, I think that is state of the art in terms of getting the best quality. You want at least 12 cores sampled, I would say. And they should be good length cores in general. Sometimes there are problems with taking biopsies and their samples are inadequate, but that's up to the urologist. They should, most cores should be at least about 1 centimeter in length. If you start having like 2 millimeter, 3 millimeter cores, even though they're sampling those areas, that's not good sampling. So core length is something also just to check to make sure that you're getting good sampling, hopefully with multiparametric MRI, and that the core lengths are pretty decent.
And so you would continue to go to that same institution, that same MRI machine. Is that critical?
Yeah, I mean, there's also variability, just like with pathology, with MRI readings. It's so people tend to think, oh, I'm getting an MRI. It's objective, but numerous studies have shown that there's subjectivity. One radiologist may say there's a PI-RADS 3 or 4, and somebody could call it a 3 or 2. So I've had patients who request, second opinions on the MRI. That's, something I'm not going to go into. That's more for the radiologist. But yeah, so it's, but that's something, to consider as well. But in general, I would say, usually, if there's no reason to switch from your clinician, you're happy and you're getting, multiparametric MRI, you're getting decent biopsies, there'd be no reason to switch from your clinician.
Okay, and second question I have, and then I'll turn it back to Howard, is Mike Rafferty. His question, his PSA in 2022 was 7.2. It looked like it accelerated in 2025 to 13.8. Biopsies over the years were both Gleason 6. His practitioner is suggesting he has treatment if the PSA goes up again. He's asking a question, what should he do?
Right. So what if it were me, what I would do is, first of all, I'm not sure if those are biopsies with multiparametric MRI. If there was multiparametric MRI, it depends what the findings were. If they found something that was very, like a PIRADS 5, for example, with the PSA of 13, I would probably say, I would probably opt more on the side of treatment. If, on the other hand, the MRI is not that worrisome, I would be, maybe stay the course. But the main thing I'd want to say is that you have really excellent sampling of that prostate. There's also something known out there called a saturation biopsy. Saturation biopsy was kind of done before MRI, but a saturation biopsy is when you get like 23 cores, when you sample pretty much the whole prostate. And those are for cases, you don't do it all the time, you do it only in a very small percentage of cases, but you do it in the cases where there's a disconnect. For example, like this, where maybe PSA is going up and up, suggesting there's something very worrisome, but on the other hand, there's only Gleason 6. So, you just don't want to miss a higher grade cancer. And the problem is, and I've seen this many times, high-grade cancer can be very tiny and focal. And so you could have like a 15-core biopsy, and you could have only a tiny speck of very aggressive high-grade cancer that easily could have been missed. And that's the whole crux of the problem with prostate. The other thing that you potentially could do with that Gleason score 6 with the high PSA is to get something like a Decipher test or other tests out there to see, is there something worrisome even within the Gleason score 6, suggesting that there may be something worse out there in the biopsy, in the prostate.
Thank you, Dr. Howard. It's all yours.
Hey, Don H. says, I would like to get Dr. Epstein's opinion on Memorial Sloan Kettering's position that a Gleason score of 3+4, where the 4 is less than 1 millimeter length on biopsy, is, quote, risk equivalent to a Gleason 6. Seems to me that this is a pretty big deal for those of us with this particular pathology, since men on active surveillance who have Gleason 3+4 presently are under stricter guidelines than those graded as Gleason 6. So you got that, Dr. Epstein?
Sure. So first of all, the one thing I'd want to make sure, it's unlikely that there'd be a Cribriform pattern 4 with, let's say, 1% pattern 4, but I've seen it. So number one, I'd want to make sure that there's no large Cribriform glands. That's low volume Gleason pattern 4. But assume it's not the worst pattern 4. It's not large Cribriform pattern 4. And you have a little bit of 4 with a 3+4. You're still at higher risk. I still think you're probably a good candidate for active surveillance. The main thing is sampling. Again, it's sampling. And so I would definitely want to make sure you had that 3+4 was a multiparametric MRI sample, 3+4, that the sampling potentially any lesion that's PIRADS 3, 4, 5 on an MRI. I think it's reasonable to get a Decipher test. What I would do with a 3+4 with the little 4 is do all the tests possible, and if everything comes up reassuring, yes, that's go on active surveillance.
Well, you've mentioned the multi-parametric MRIs, and I'm detecting a move towards biparametric MRIs. I know that you're a pathologist, but do you have any opinion about that?
And currently, at least standard practice, at least all the ones that are in use for most of the places are still multiparametric. And even then, again, they're not being used routinely. So I don't have a lot of experience with the bipolar MRI. That would be more a question for the radiologist.
I got you. Let's see. Jonathan P. asks, let's see, on a second opinion biopsy read for a patient with Gleason 6, how significant is an upgrade to a low-grade Gleason 7, 3+4, 1%, with no large cribriform? And, well, it sounds like he has perineural invasion. How serious are these in making a decision to move into active surveillance?
Right. So I would say, again, similar to what I answered the last question, I would say it's incrementally worse to have a 3+4 than a 3+3. It's not a black or white, like 3+3 is active surveillance, 3+4 is not active surveillance. But it's again, incrementally worse. And so you would want to do, again, just like I said last time, make sure you had imaging to make sure that you sampled well any abnormal lesions seen on imaging. Potentially get a decipher on that 3+4 core to see kind of, is it a good 4 or a bad 4? And then be followed closely with repeat biopsies. The whole thing with repeat biopsies is you're hoping that it'll detect worse cancer if you're followed closely before, at a time still where you can be treated and it doesn't impact adversely prognosis. And most studies have shown that's actually the case. So the only difference is you might get followed with repeat biopsies a little bit more closely in between with, let's say, a 3+4 than a 3+3 also.
Yeah, David.
Okay. On gene mutations, can you all hear me all right?
Oh, yeah.
There's the BRCA1 and BRCA2. Are there any other gene mutations that patients should look at when considering prostate cancer?
Yeah, there's several. There's ATM, there's CHEK, there's several out there. There's HOXB18. Some of these are quite rare, but there is potentially as an option for patients with, usually it's at kind of the opposite scale of active surveillance. So all of these gene mutations are exceedingly rare in a Gleason 6 or even a 3+4 = 7. You tend to see these mutations in the higher grade, Gleason 8, 9s, and 10s. Or even 4+3s. So there's a move, or if you have cribriform cancer or intraductal cancer, those are all enriched for these gene mutations. So typically, for example, we will order these genetic panels for patients with high-risk prostate cancer. Again, Gleason 8 through 10, intraductal cancer, large cribriform cancer. Those are the patients that typically those genetic tests will be performed.
Thank you.
And so, to some extent, some of them, like the BRCA ones and HOXB18, is to detect if there's a family history of prostate cancer, so you can help out other family members as well for early detection.
Great, thank you. One more question, then I'll turn it over to you, Jeff. I know you factor in the prostate density index frequently. What about percent-free PSA? Is that something that might, when you're kind of getting to fine tuning, you're looking at your situation?
Yeah, percent-free PSA. So the way percent-free PSA goes is certain percent of your PSA is just floating around free in the blood. Certain amount is bound to proteins. And the percent-free, the higher, it's actually opposite of regular PSA. So the higher the PSA, the worse it is for the cancer. Higher percent-free PSA, the better it is, the more likely you have not cancer. So percent-free PSA, once you have cancer, it's not really helpful. It may be something to help detect prostate cancer. There's a lot of controversy as how much helpful it is. There's a lot of other tests out there, serum tests that are commercial tests that are out there that are probably better than just percent-free PSA. But it's a test that may help if PSA is going up, just like PSA density, one more test to try to say what's the likelihood you have cancer. But again, once you have cancer, percent-free PSA is not helpful.
Thank you. Jeff?
Yes, thank you, Doctor. Some of us are growing older once we get up in our 70s and 80s and who knows beyond. And it's clear, and I've heard from other practitioners that maybe they could, if you will, not intensify our tracking, if you will, through biopsies and MRIs. Assuming we have normal health and we do not have a family history, what do you think about as we grow older? How often should we be screened, biopsies, etc.?
Yeah, so I'll answer that kind of two different scenarios. So for the patient who's on active surveillance, let's say, and your question is, when can I stop active surveillance? I'm getting older, can I just, be done with it? I think the answer is, once you hit 70, some people say 75, what you want to do is definitely have like an imaging, just to make sure there's nothing bad in there. And if there's, still no worrisome lesion, your last biopsy was good, and your PSA is not that high, that's reasonable to, and maybe go off active surveillance. But that's, again, a personal decision to talk with your clinician. Now, the tricky part about growing old is, as I mentioned earlier, there is a correlation. The older you are, there's an increased risk of more aggressive cancer. So on one hand, you have kind of competing factors. You're getting older, you're more likely potentially to die of other causes. You're more likely, even if you have cancer, to outlive the cancer. So that argues, let's not worry about prostate cancer. But on the other hand, there's the data showing that the bad cancers are often in the older people. So that's, a conflicting thing. So what do I do? And so in a sense, you don't want to ignore cancer at the older age, but you do want to factor in the age of the patient as well. So, in terms of screening for PSA, I guess what I would think is, and again, you can look at the NCCN guidelines. I don't know the exact cutoff, but there's a certain cutoff that if your PSA is a certain value below this, there's data to say and predict that you are unlikely to have a significant cancer the rest of your life, and you can probably stop PSA screening. And so, that's, again, important information. But that's, again, if you have a low PSA and you've reached a certain age, pretty much you can stop PSA screening at that point, because the likelihood, even if you have cancer, it's not going to be a bad cancer. But again, I don't want to minimize that just because you're older, there's potentially, you don't have to worry about prostate cancer. Because again, one of the factors, we are living longer and longer, and we don't want to end up with a Gleason 8 or a 9 or 10 at age 75, when potentially we could have lived to 90 without, without having a bad cancer. So it's a balancing act.
Excellent. Thank you, doctor. So then there's another question. This whole thing about BPH and PSA, is there not, would you think that there's got to be some way that, since they can get in and they scope the BPH patient, would that not also be helpful to the pathologists and other clinicians? In other words, you're inside the prostate. Can't they have a good look around? Is that not practical?
Yeah, it's not a matter of practical. So it's a matter of two things. One is about 85% of prostate cancers begin at the outer edge of the prostate, away from where the urine comes out. That's where, for example, the rectal exam or the biopsy typically goes in, sampling the back of the prostate, not the inner part. If you think of the prostate like a donut, and like the inner part of the donut, that's what they would do with a scope going up into the urethra through the penis. And only about 10 to 15% of prostate cancers start in that area, and they tend to be more the lower grade cancers. The more aggressive cancers are not where we can really look. It's in the back of the prostate. And that's where you need the imaging and where you need the biopsies.
Okay, thank you, doctor. Howard, over to you.
Okay, this is just like an anchor team on TV, isn't it? Or not. At any rate, I can't tell who wrote this, but he says, my urologist, and those in slides later read by someone at Hopkins, while you were still there, Dr. Epstein, advised me that I should go on active surveillance because my cancer was labeled low to very low risk and less than 5%. My biopsy in 2023, after a third MRI read, was PIRADS 4. He had a couple of PIRADS 4. His latest biopsy came back with no Gleason score, which surprised me. His urologist said that no cancer was seen because there wasn't one large enough detected or reported during the examination, hence no score. And his urologist recommends he stay the course on surveillance, but maybe someday his prostate might have to come out. I don't know about that attitude, but okay, so year after year, somebody gets a reading, and and suddenly either the MRI says there's nothing there, or the biopsy says nothing there. How common is this, and why is this?
Yeah, it's a good question. So first of all, MRIs are not foolproof. So there are false positive MRIs. You can have a lot of inflammation in the prostate, and that can give a high PI-RADS, even though it's not cancer. And there are some things we just don't quite understand what makes a higher PI-RADS lesion and why sometimes there's not cancer, or sometimes MRIs can miss the cancer too. So again, it's a good test, but it's not a perfect test, like everything else probably in medicine. Now, what happens, like you said, when I've had patients ask me, did my cancer disappear? Did it regress? There are some cancers actually in the body that can regress and auto kind of destroy itself. Prostate cancer is not one of them. Prostate cancer will not kind of fade away or die out over time. It just doesn't do it. But what it means, if you have a small cancer, and the biopsy may miss that small cancer. So you could end up having cancer on your initial biopsy or on active surveillance. You might have cancer on 2 or 3 biopsies in a row, and then one biopsy shows no cancer. And again, it doesn't mean your cancer was cured in the sense that it disappeared. But what that is, and we've shown in a study, that's a very favorable finding. It's actually it's a good finding. And what that means, if one of your biopsies shows no cancer, your set of biopsies show no cancer on any of the cores, that means it's probably a very tiny cancer, and that's a really good thing to staying on active surveillance.
You know, I noticed in the chat box, there was a question asking, you just used the word cured, and somebody, you know, wasn't questioning you on what you just said, but in general was saying, is cure a proper word to be used in this context?
Understand, yeah, and I probably shouldn't have quite used the word cured. What I meant is the good likelihood that you are not going to need active treatment during your lifespan, for the most part, for your prostate cancer. But you're not cured of it, right? In a sense, and I just said that you never quote cured of prostate cancer on active surveillance because the cancer is still there, no matter what, even if it's a small cancer. But if you live your whole life and you're never bothered by that cancer, then that cancer didn't affect you per se in your overall lifespan, and you know, active surveillance worked well. You can get cured with obviously various forms of active therapy, but then the risk is potentially overtreatment for a cancer that would have done well with active surveillance.
Sure. David?
Yes, thank you, doctor. This was incredibly informative. I really appreciate it. Stuart J. and David R. were both asking questions about the 3+4 percentage 4 biopsy. If you want to elaborate on that a little bit, one sub question I had was, did you say that if the percentage 4 is 10% or less, then that slides more toward grade group 1? Is that fair to say?
Yeah, what I would say is if you have a 3+4 with less than or equal to, let's say 10% pattern 4, with the caveat that it's been well sampled, again, probably with an imaging with MRI, so you feel like it's accurate, and accurate pathology, because again, just like anything else, percent pattern 4, somebody could say 10% and somebody else could say 30, 40%, so it can vary. But let's say everything all aligned, that you're comfortable that that's truly, you know, less than 10% pattern 4, well sampled biopsy. It's on the low end. It's on kind of the favorable side of a 3+4 that would potentially be a candidate for active surveillance, factoring in all the other things, making sure it's not a PI-RADS 5, making sure the PSA is not very high, you know, making sure the patient is comfortable with that, you know, et cetera. And maybe, again, looking at a Decipher score. So I would say going on active surveillance with Gleason 7 is definitely feasible, but it's at a slightly higher risk than a 6. And so therefore you just want to pay extra due diligence to making sure that everything's lining up, that this is favorable 3+4.
Thank you very much for that. And if I could ask another question before I turn it over to you, Jeff. These darker spots that they can spot in an MRI of the prostate, some call them masses, some call them lesions, some call them tumors. Is it fair to say it's not a tumor or a cancer tumor until there's been a targeted biopsy that shows there is some cancer in there? Or, excuse the complexity of the question, or is every mass in and of itself sort of at least a Gleason 6 or something to be of concern?
No, they really shouldn't. I mean, because like I said, there's false positives with these imaging. So they
Okay.
should always describe it as an abnormal finding. So they call it lesion. It should be called like a PIRADS 4 lesion, meaning it's abnormal on the imaging, but it's not proven cancer or tumor until there's a biopsy that shows it.
Okay, that's helpful. Thank you very much. Over to you, Jeff.
Thank you. Thank you. Dr. Patrick Shannon has asked the following. For very low risk Gleason 6, you say the risk of upgrading is 15%, but over what time period?
Yeah, so that's typically the first few years, because most of the time that upgrading is going to happen on the first rebiopsy, let's say a year after you've been diagnosed, maybe the second year after you've been diagnosed. Once you start, for example, if you have start out with, let's say, a 6, your second biopsy is a 6, maybe the third biopsy is a 6, it starts becoming very unlikely that your next biopsy is going to be a 7, because it means you've sampled this well several times, it's still a 6. So most of the time it's going to get higher grade. When you find that it was undersampled the first time, you're going to find that in that first 2 or 3 years of your rebiopsies. Again, the longer you still have 6 on rebiopsies, you can start lengthening out when you have those rebiopsies, the more reassuring you truly have a very low risk cancer.
Thank you, doctor. And then John Craig has asked, Dr. Epstein, please comment on this. One urologist I consulted said that using the same number of cores for a 30-gram prostate versus my 150-gram prostate resulted in inaccurate readings.
Yeah, I wouldn't say that's necessarily true. Typically, when you have a 130-gram prostate, probably 90% of that prostate is BPH, benign growth of prostate. So it turns out that cancer, for the most part, doesn't increase the size of the prostate like BPH does. You can have a whole cancer filling up the prostate, and it doesn't mean the prostate's going to be a big prostate. So, but again, they can tell on imaging that most of that 130-gram prostate is benign looking, and therefore, you don't have to do as much sampling. You might have to do a little sampling because the whole posterior part of the prostate is kind of stretched out also. So I'm not saying you wouldn't increase the sampling somewhat, but it's not proportional to the size of the prostate, how much sampling necessarily you have to do. There's also been a correlation that small prostates tend to have more aggressive cancer than larger prostates. And part of the reason of that is large prostates with cancer that are detected cancers, part of the reason they might have been detected is the large prostate had a lot of PSA, patient got a biopsy, because of that high PSA, they found a small cancer. Whereas a small prostate doesn't produce a lot of PSA, so they're not being biopsied unless there's usually more of an aggressive cancer. So paradoxically, those big 130-gram prostates, probably are more likely to have indolent disease in them than a small prostate, especially if you're looking in terms of cancer.
Looking at that and then following on, and I'll turn it over to Howard, doctor. I mean, we understand that area of our body, particularly the prostate, has a lot of nerves and nerve tissue going through it. I mean, what is the trade-off having multiple biopsies, which possibly damage our nerves and et cetera in that region of the body?
Yeah, there's definitely been recognized that there is an increased risk with biopsies. There's a risk of sepsis with transrectal biopsies. Hence, there's been somewhat of a movement to go to transperineal biopsies through the skin where there's less of a risk. But even if you go transperineally, anytime you biopsy the prostate, you have scar tissue there. You are damaging potentially nerves and potency. You're also, if down the road you undergo surgery, for example, it makes it more complicated because there's more scar tissue. And it's also just obviously an uncomfortable procedure. There's bleeding sometimes associated with it. So there's definitely a recognition. Can we space out the number of biopsies for men who are on active surveillance? Also, the longer the men are being on active surveillance, there's just a limit to how many biopsies these men can have potentially. And so based on the pathology in large part, based on the volume of the cancer, based on the imaging, et cetera, there's not hard and fast rules, but there are definitely individualization to space out the biopsies in patients who have a lower risk of having worse disease.
Righty. Thank you, doctor. Howard, it's all yours.
Okay. Dr. Epstein, you were sort of edging into BPH territory a few minutes ago, and nodules. Nodules were in the news this week with former President Biden, along with all his other aggravations, getting diagnosed with a nodule. Maybe you could explain what a nodule is and how often are they being biopsied? I mean, are they, are these nodules typically still being found with digital rectal exams? I mean, how are they even coming up? And I forget if Biden's like 82, should he be messing around with digital rectal exams? Isn't it enough already?
Yeah, so the issue with, so what a nodule is typically when the word nodule is used in prostate, it is something felt on a digital rectal exam by, it could be the primary practitioner or urologist. So a nodule is very nonspecific. It means there's like a little bump in the prostate when they do the rectal exam. Now, I've been told by innumerable urologists that the rectal exam is a bad test. It's very non-sensitive, non-specific. It misses tons of cancers, and it has a lot of false positives also. And the only reason potentially we do it is it's free. And it's easy in a sense, not easy on the patient. I'm not minimizing, patients don't love them, but it's, you don't need a complicated machine or anything to do it. But in all honesty, a lot of urologists, of primary practitioners are kind of getting away from doing digital rectal exams just for that reason. But occasionally, a digital rectal exam will pick up an abnormality. Now, a nodule, it depends on what that nodule is like, and that's part of the problem with the digital rectal exam, the DRE. A nodule that's very soft and compressible and kind of squishy, that's probably just benign prostate tissue nodule, BPH nodule. A nodule that's very firm, they use the term indurated, irregular, is also a kind of a buzzword for something worrisome. So a kind of a uniform, round, regular, squishy nodule that's compressible, those are all buzzwords for it. Probably nothing, don't worry about it. An indurated, hard, fixed, irregular nodule, that's really worrisome for prostate cancer. That, again, has to be biopsied. Now, it's been shown that, PSA is going to detect almost all of the cancers that a rectal exam will. Occasionally, maybe a rectal exam will pick up something that a PSA might not. And that's why, because rectal exams are, quote, free and easy relative to do, that's why they're still being done. But they cause a lot of false positives. And so in somebody like Biden, you'd have to know the nature of that nodule, how suspicious it was. Now, in terms of whether somebody 82 should be getting a digital rectal exam, it's probably highly unlikely that they should be getting digital rectal exams at age 82, partly because it's just not a good test, period. But, how VIPs are treated are, sometimes totally different than how necessarily common practices.
Well, the platinum care isn't necessarily the best care sometimes.
Yep, no, we always said that in pathology. Sometimes in pathology, when we were told, oh, a VIP specimen is coming in, everybody, hands on deck, treat it specially. That's the highest risk something's going to get screwed up. You're almost better off just letting it go through like you do with all the routine, but the routine is good. We set up safeguards to do it well routinely. So,
hey, Jordan E says, do I need a fourth biopsy? And, again, we're not trying to give him medical advice, but let's consider what he's been through, and maybe this can help everybody. He says he's 77. He was diagnosed in 2021, PSA of 4.3. He had his first biopsy December 21. He was a Gleason 6. He had a second biopsy in December 22 by you as a second opinion. 12 cores, only 4 detected cancer, Gleason 6. It goes on and on. Let me see. Well, it's not that much on and on, but I'm trying to summarize it. Let's see. Most recently, he had a test. His PIRADS was 4, I think. Only one lesion. It was 1.2 centimeters. His last 2 PSAs have been 8 and 9. My urologist wants to do a 4th biopsy in July. I'm going to take PSA before that to see if it's still high. Would you recommend a 4th biopsy?
Yeah, I would, not regardless of what the PSA is. I mean, it is worrisome that the PSAs jump double. Again, PSAs can go from 4 to 4.5 to 5 to back down to 4. That kind of a PSA plus or minus 10%, even 20%, kind of is almost noise. It can just be variation in the test, especially if you have it done in different labs. But a doubling of the PSA is abnormal, but more worrisome is PIRADS 4. That is a high-risk lesion. And so you definitely want to be sampled, especially if your prior biopsies or the patient's prior biopsies were not done with imaging. And so who knows what was there, could have been missed easily. So I would say even at an older age, if there's a PIRADS 4 lesion that has not been sampled, I would want to know what's going on there.
Okay. I'm going to steal from the chat room because I was pretty interested in
But let me
this.
just qualify, because again, I'm not the patient's doctor. You need to know conflicting, competing medical issues. For example, hypothetically, if the patient had a horrible heart disease and was potentially at risk of dying in 2 years, I might say no. If the patient was a healthy 70-something and exercises and has a good life expectancy, definitely work up that PIRADS 4.
Okay. I'm going to bring up a guy from North Carolina, Scott. He asks, how should a man that has treated focally think about PSA density score? The denominator is now surgically altered to be smaller than prior to focal therapy. Is there a corrective formula for the math in focally treated PSA density math?
Yeah, I would say no. Yeah, I would say once you've altered that prostate and removed part of it, there's really no good way to calculate the volume in the PSA density, and plus even partially destroying the prostate can alter the PSA. So I would just say you can't use PSA density at that point.
Okay, David, to you.
That was a good answer. I had that same question. Thank you so much, doctor. From Russell A, he's asking risk of spreading cancer by means of a biopsy. I think
Right.
you know exactly what I'm talking about, so I'll
Sure.
leave it at that.
Yeah, that's a good question. There's virtually no risk that the needle biopsy will spread the cancer. So that's something you don't have to worry about. That does exist in some other organ systems, especially with very aggressive cancers, but it turns out with prostate cancer, it just has not been an issue. So that's something, not to factor in.
Okay, great. How frequently should someone get a biopsy? And you've kind of addressed this a couple of times, and I'm sorry to be a little repetitious for everybody. Gleason 6, had a biopsy, wait 1 year, wait 2 years, wait 3 years. If all other things are kind of stable and fine, the PSA is not changing, how far can we go between biopsies? Let's just say if the person's under 77.
Yeah, so typically what's done is called a confirmatory biopsy. So you get your initial biopsy done. Let's say it's a Gleason 6, you're thinking of active surveillance. You typically want to, in a year, get another biopsy. And again, I would say make sure it's with MRI guidance, at least multiparametric MRI guidance, to at least, quote, confirm that that's what you have going, that you have a good low-risk prostate cancer. Once that has happened, and you have now 2 biopsies with Gleason 6, and let's say there's no worrisome lesion on imaging with MRI, then potentially start talking to your doctor about, can I space out these biopsies? Maybe go 2 years for the next set, and then maybe 3 years. But that's all going to be kind of an individualized process. But I would say you first want to have at least 2 biopsies done with a year apart that show favorable disease before you start spacing them out.
Thank you. That was Norbert's G's question, and I'm going to turn it over to you. And thank you, doctor. I'll turn it over to you, Jeff.
Thank you. Thank you. Hey, doctor, a good question here from John Craig about perineural invasion. He says his latest biopsy report shows such. The biopsy was mostly grade group 1, but 1 core, grade group 2, 5% Gleason 4. What is the significance of PNI?
Yeah, so PNI so we did a study with PNI, looking on men just like this with active surveillance, and found that 3+4 with PNI does predict for worse disease. And so it is a worrisome feature, but again, it's not a black or white saying definitely undergo, for example, definitive therapy. It's one feature that's, a little bit more worrisome for that. I would also say the study that we showed that PNI was worse on active surveillance, it's the only study that has really looked at this. So like anything else in medicine, even though that was our study and I believe it, I would want other studies to confirm it and on different patient populations, et cetera. So the way I would look at it is, again, if you had a 6 that went to a 7 and you have PNI, even though it's a small amount of 4, look at other parameters. Make sure you don't have a worse MRI. Make sure you've had these biopsies done on MRI. Maybe consider a Decipher score that, again, gives you some either reassurance or potentially, pushes you to active treatment. There's also there's an AI program out there for active surveillance. Again, there's a lot of different commercial tests out there. None of them are by themselves, I would say, the answer to everything, but they just give you one other piece of information that if everything lines up favorable, that gives you more reassurance. If they start lining up unfavorable, again, that may push you to treatment.
Okay, doctor. And then you've mentioned genomic tests, Oncotype, Polaris, Decipher. Are any of those helpful in a case as you just described, where if you're looking for a tiebreaker or something's helpful to help the man understand what are his risks?
Yeah, so
but
again, there are
it's on
multiple out
Zoom, but
there.
it was like,
Yeah, there are
it
multiple
started
out
at 9 and
there.
it kept saying that
We
the
use
attendance is full, you can't get in.
Dirk, would you go on mute, please? Dirk Wellbrock? Thank you.
Yeah, so
Sorry about
again,
that.
there are multiple tests out there, all commercially available. We use Decipher, the NCCN has recommended Decipher, but you're right, there's Oncotype DX and there's others out there. I guess there's a limit to how many tests you want to do to see if they're all favorable. These tests are very expensive, they're thousands of dollars. I'm not sure about, does insurance pay for them? So I'm not sure I would do multiple genetic tests. I would do probably one that and see what that shows because they're all kind of trying to show similar things.
Okay, thank you. Back to you, Howard.
Okay, I don't know how much longer we should go on. I think we could go on all day, Dr. Epstein.
Yeah, we probably, maybe a couple more questions and we'll call it that.
All right, I will. Okay, I guess we'll close. I have 2 questions. Actually, you got a lot more than that, but maybe we can schedule a program.
Yeah, I'd be happy to have just a question, and even without a lecture, just a question and answer period, a free form question and answer period for patients.
Why don't we
That'd be great.
plan on that, and I'll talk to you and we'll find a time and we'll get everything lined up.
Sure.
I have a question here from Eric L. And, we touched on focal therapy, briefly, but in a different way. He's asking you to kindly elaborate on your current thinking regarding utilization of IRE and HIFU for low-grade lesions. I mean, I know the standard. The standard is don't do it if you're have a Gleason 6, but
Right. Yeah, my thought with focal therapy is, if you have a low-risk cancer, I would probably recommend going on active surveillance over focal therapy at that point. Now, some people may be undergoing focal therapy for, let's say, higher risk cancers, like a 3+4 versus definitive therapy. It is riskier. That's all I will say. It's riskier. I'm not saying it wouldn't be successful for some patients, but it's definitely for higher risk cancer. It's a riskier treatment than radiation or radical prostatectomy. And it's, again, something to talk about with your clinician and recognize the increased risk. I would say it's not typically standard therapy, but it may be useful in certain circumstances for certain patients who are, not good candidates for surgery or radiation. But for the very low end of disease, I would probably recommend active surveillance over focal therapy if somebody's a candidate for active surveillance.
hey, now for our closer. A couple of years ago, I did a book for the College of American Pathologists. And as I recall, one chapter in there had to do with how radiology and pathology were sort of merged into a specialty in Brazil. And so I see George G asking here, and this is a question for you, do you think there will ever be combination of blood, urine, semen, and/or other non-invasive tests that will be able to replace prostate biopsies?
Well, there's always a potential for anything. Medicine is constantly changing. I would say it's not in the near future, but who knows what the future holds for us? I mean, there's always exciting, discoveries being made. It's not something that I would say for men who are being currently treated and being followed, thinking, oh, maybe I don't need a biopsy in a year or 2 or 3 because something else will come out that'll replace it. I think that's probably less likely.
Well, I got you, and really appreciate your time, and we'll figure out another time you can come back and just take questions.
Sure, my pleasure.
Okay. And thanks for everybody for coming. Sorry about the delay in starting. And Jeff and David, thank you.
Our pleasure. Thank you, Doctor. What a
Thanks, Doc.
tremendous
be here.
contribution you've
Yep,
made
thank
to
you.
us. Thank you.
Thank you
Thank
for the
you.
opportunity.
Everybody attending
Thank
too.
you.
Great questions.